Now, my problem with it is that there's a lot of false pocketing. So what happens is that it depends on the depth and the position of the implant placed, and also on restoratively the length and the contour of the abutment. So if you have an overly contoured abutment, you might actually have less pocketing, that you can see or that you can probe, but that doesn't mean that there isn't a pocket there. So that means that you're not actually diagnosing it very well. Then we look at crestal bone loss. So this is the idea of taking periapicals, looking at bone loss radiographically, and then measuring that bone loss and comparing it to previous x-rays to see whether or not there's any bone loss. Now you can see here that I like this kind of method where you actually measure the implant length and then you divide the amount of bone loss by the length to create a percentage. But the problem is that there are no agreed guidelines. We have no idea who has the correct guideline, what is, early, moderate, or severe bone loss. Another problem is that actually every time you place an implant, you will get natural marginal bone loss of around 1 millimeter or 2. So how can you differentiate between natural marginal bone loss and actually pathogenic bone loss, which could lead to periimplantitis? And then lastly, the problem is that we're taking these 2D periapicals, which are only displaying interproximal bone. So what happens if there's buccal or lingual bone loss? We're not able to see it. And it's quite difficult to be able to justify taking 3D CBCT scans once a year to check for buccal or lingual bone loss around an implant. So we most likely don't do that. Then we've got the classic bleeding on probing. 91% of implants will have some bleeding on probing if they have periimplantitis. My problem, it's subjective. It really depends on the clinician, how hard they're probing. It's invasive. And lastly, you're actually spreading bacteria, which obviously you don't want to if there is an infection present. And then we've got lastly, the presence of suppuration and or a fistula. So basically pus coming out of the pocket. Now, in my opinion, it's too late. If a patient's having pus coming out of their pocket, then there's a lot of problems going on here and a lot of treatment has to be done. And the idea is to not get to this stage ever. You don't want to have this type of problem. So just a quick recap of the problems with the quantitative methods are that they're not standardized. Every country has different criteria, which means that if a patient's going between numerous clinicians, we never have a proper, diagnosis of that patient. And that leads on to the fact that it's subjective. Every clinician will actually measure things differently. And it's all based on our eyesight, basically. It's inaccurate. And another problem is you're not actually able to monitor treatment or progress. So if you are to diagnose periimplantitis, what is your end goal? Is the idea that you're meant to have absence of bleeding on probing? Is that a good enough kind of treatment aim? Or is there another thing that we can actually monitor and track? And lastly, you're often relying on clinical symptoms. And by this point, it's often too late if the patient's actually having problems with their implant. So if we move on to the kind of more quantitative methods, the first one is the idea of biomarkers. So there are numerous biomarkers that are found in the saliva and the gingival crevicular fluid inside the mouth. And one of the kind of biggest biomarkers at the moment is AMMP8. So AMMP8 is a major collagen-lytic enzyme, and it causes active periodontal and peri-implant degeneration. So it's a really great biomarker that we can actually find in the saliva and the gingival crevicular fluid, and it will show us whether or not there's any type of collagen breakdown. Now, what's good is it's point of care. So it takes about 5 to 10 minutes. The patient can stay in the chair and you will have the results within 10 minutes. It's early detection of subclinical inflammation. So this means that it's often not symptomatic. The patient has no idea that they have this inflammation or the early beginning of periimplantitis. And you're able to kind of detect it and stop it before it develops into anything worse. And then it also indicates active periodontal tissue breakdown. So if you're having kind of collagen breakdown early on and you have elevated levels of it, then that suggests that you have periodontal tissue breakdown, and that will suggest that there is some periimplantitis going on. And so another really important thing is the ability to diagnose and monitor treatment outcomes. And we'll go on to this in the next slide. But the idea that if you're able to diagnose a patient with a number and say, okay, you have elevated numbers, levels of AMMPA, we want to get you down below 20. And so every 3 months, we're going to keep on doing this test until you get below 20. This is a treatment outcome that is easily kind of achievable. There's an easy way of tracking it, and it gives a lot of motivation to the patient as well. And then lastly, it's non-invasive. So unlike bleeding on probing, where you're literally probing the gum, this is non-invasive. So the only kind of flaw I would say is that additional machinery is needed. You will need to have the machine in the practice, but in my opinion, it's an investment which will pay back very quickly. And it's something that I genuinely don't think I could work without anymore. So if you're comparing AMMP8 to other biomarkers in the saliva and the gingival crevicular fluid, if you look at the graph on the right, you can see that AMMP8 has the best sensitivity and the best specificity compared to any other oral biomarkers, and also are kind of gold standard for diagnosing peri-implantitis at the moment, which is bleeding on probing. So you can see here the bleeding on probing is not as good as the AMMP point of care test, which is all the way up here and very stable. So AMMP8 has been shown to be more accurate than any other biomarker, and also more accurate than qualitative diagnostic methods currently available to us. So this is how it kind of looks. This is your machine. There's 3 different types of tests. You've got the implant safe test, which is specifically for implants, and you place a little strip basically into the pocket where the implant is. And then you've got the oralizer, which is more general. It's more of like a screening tool to see if there's any elevated collagen breakdown in the mouth generally. And the last is specific for periodontal disease, so the PerioSafe, and that's for patients who have periodontal disease on specific teeth. And again, you just kind of put a small litmus paper inside the pocket. And here you can see this personalized prevention plan that can be created and followed by the patient and the clinician, and that can be carried on from clinician to another clinician, and it's very easy to read and convert. Then we've got other ones, which are oral microbiome testing. So the idea of looking at the bacteria, we all know that peri-implantitis originates from basically pathogenic bacteria surrounding itself around the implant and causing inflammation and infection. So with oral microbiome testing, it's looking at the idea that with peri-implantitis, you have higher counts of 19 bacterial species, and you can see them all here. And interestingly, these 19 bacterial species generally are very low in diversity. And there's very distinct signatures between mucositis and peri-implantitis. So that technically means we could be able to differentiate between perimucositis and peri-implantitis with oral microbiome testing and looking at specific bacteria, particularly Fusobacterium nucleatum, P. endodentalis, and T. forsythia, to see whether or not there's elevated levels of them in the mouth. Problem is, it's not point of care. It needs external testing, which can take a couple of weeks. It's expensive, and the research is not fully established there. So can it actually impact your treatment? Can you justify charging your patient for that when you don't really know how it's going to help? And also another problem is the oral microbiome is impacted by a lot of other factors. So you have to take into account the fact that maybe the patient's smoking, they have poor nutrition, they're not brushing their teeth, and that will impact the oral microbiome, and it might not necessarily be indicative of peri-implantitis. So this one take with a grain of salt, in my opinion. And this is something that I'm looking into, but I'm still not completely convinced in. And then lastly, the idea of pro-inflammatory cytokines. So we know that with peri-implantitis, there is inflammation and there are elevated levels of certain interleukins, so IL-1, IL-8, tumor necrosis factor, and obviously the MMPs that we were just discussing. So technically, we should be able to potentially look and screen patients for increased levels of these pro-inflammatory cytokines, and that could indicate inflammation in the mouth. Now, the problem is that mucositis and peri-implantitis both have inflammation, so it's very difficult to differentiate between the two of them. It's expensive. Again, additional machinery is needed. As I said, you can't differentiate between mucositis and peri-implantitis, and you also can't differentiate between local and systemic inflammation. And I've tried this test a few times, but the problem is that if a patient has, for example, chronic systemic disease like rheumatoid arthritis, their levels will be elevated, but that doesn't mean they have peri-implantitis. So this has not been refined enough, and still a lot of research needs to go into this. But this is, again, something that is in the works, I think. So in conclusion, There are qualitative methods for diagnosing peri-implantitis. They're subjective. They're not standardized. There's not, one criteria that every country and every clinician can follow, and that's a major problem. And often we are diagnosing problems far too late and when clinical symptoms have already occurred. Oral microbiome testing, it's very promising, but it's very premature. And there's not very much research into the clinical application. Same with inflammatory markers. It's limited research, unable to differentiate between systemic and local inflammation. And lastly, AMMP8 biomarker testing, in my opinion, is one which has had over 500 published papers. It's very there's a lot of research that's been going into it. And it's showing that AMMP8 is the most stable, most accurate diagnostic method compared to other quantitative and qualitative methods. And using the biomarker testing, this is what I use myself in the practice now. I'm able to give a number to the patient and say, okay, your level is 60 and we want you to get down to 20. This is how we're going to get you down to 20. And you create a treatment plan. And I think in my opinion, this is the future of dentistry and the way that we need to be starting to diagnose peri-implantitis and even perimucositis as well. Thank you for listening. I know it was a quick one, but if anyone has any questions, please let me know.
All right, good afternoon. Just let's start because we only have 15 minutes. I'm very delighted to be invited to this webinar. I think it's a very important topic, the peri-implant diseases we have around our implants or even around teeth. So Victoria Simpson, thank you for your very kind and interesting lecture. It's always nice to have a native English speaker to listen to. It's very nice on the ears. All right, I would like to talk to you about the beneficial effect of oxygen on dental surgery. Let's see if it's working. No. There we go. Well, I have my private practice in Bussum, that's the Netherlands, and I'm graduated in Amsterdam in 2008. And after a few years, I did a postgraduate program in Nijmegen, that's near the German border, where I mainly specialized in implants and restorative dentistry, and I'm recognized as a specialist in this field. And besides the work I do in the clinic, I have a passion for photography and dentistry. And in a few years, I just started to use these pictures for clinical lectures and publications. Before the COVID time, I was very busy with lecturing all over. So that was a very nice hobby. And at this moment, we're all condemned to the webinars, but it's a little bit less fun, but we can still proceed with each other to talk about dentistry. Besides my work in my private practice, lecturing, and also being an author and editor for magazines, I also started with my own private implants academy. And so 2 years ago, we started with a nice group who come for 8 full days to learn about implants. So let's talk about Blue M. Normally I have a longer lecture, but let me see, I want to remove my face, that's better. Normally I have a longer lecture about gingivitis, periodontitis, perimucositis, and wound healing, and what especially this oxygenated product does on these diseases. But since the time, I will just keep it under 15 minutes. I will mainly talk about the effect of this oxygenated products on inflammations around implants. So this is the product. It's like a gel with a lot of oxygen inside. And as you can see around this healing abutment, you see the bubbles, and that's the oxygen where we have around these oxygenated products. So the active ingredients of the Blue M are sodium perborate, honey, and xylitol. And you may think honey is that sugar. No, it's just the active ingredient which releases oxygen when it comes in contact with the saliva. And some other ingredients are methylsilicates and lactoferrin. So it comes in a toothpaste, mouthwash, and oral gel. And I find it in my private practice very useful for my patients because I'm not a big fan of the chlorhexidine products. And I see in my clinical cases almost the same tissue response around of the soft tissue when my patients rinse with the mouthwash instead of the chlorhexidine. And if you have the oral gel, it has even a larger release of active oxygen. So it's a product which started a few years ago, and we see a lot of in the clinical cases around the world of many famous doctors, we see them using these Blue M gels, and that's something I think is clinically proven. The evidence is now coming. They're investing a lot in the research at this moment. So we've got some very nice evidence articles coming up, more in vivo and in vitro researches on the effect of these kind of products. So I want to this afternoon just talk on a few cases on how it might work. You might recognize cases like this you might have in your private practice. We do a lot of work to restore a lateral incisor or central incisor. We want to have it aesthetically pleasing as we can. So we do bone grafting, we do soft tissue grafting, we use a temporary crown to create an emergence and cervical profile of our tooth, and we're sometimes very happy with the result. But it never stops there, of course, because you must continue to follow up your case and try to keep it healthy. So this case, which I also published in a clinical textbook, at 1 year post-operative, everything was going very well, and also the X-ray showing very nice result. But in 2 years, this came up, and this is a case of mine. I never show a case of others because I have enough mistakes on my own. And in 2 years, you can see quite a large inflammation around the lateral implant and the lateral tooth, and there's some marginal swelling. But if you look at the teeth beside, you can see that there's some plaque formation around the central incisor and the canine. And the first thing we do is, of course, probe and see if it's perimucositis or peri-implant disease or peri-implantitis. And as we made an X-ray, although there's no visible clinical attachment loss around the implant on the X-ray, you can see that there's a massive bleeding around our tooth. So how do we treat cases like this? Of course, we have the successive treatment after we've done it is based on the cleaning, a lifestyle change of the patient, and a change of supplements. And supplements change is changing from normal toothpaste to a Blue M toothpaste using the mouth rinse and the gel around the soft tissue to maintain it over long term. And this same principle we use around gingivitis, periodontitis, we use also around peri-implant mucositis. So we try to clean the patient. So what's the difference between a tooth and implant? We already have research around this of 1992 of the very nice research on beagle dogs of Berkeley in 1992, and they found that the inflammation residing in the mucosa without bone loss is very similar with gingivitis, and we can do the same kind of treatment for these cases. So what we normally do is we clean the site. I clean the site. We give some additional instruction to our patient. We try to give them a lifestyle change in the way they clean their teeth. So they must try to repeat this every day. And then we supply some active oxygen, some supplements of oral gel around the site. And we ask the patient to repeat this for a few days. So the lifestyle change is very important in our case, because we can tell our patient, you should brush better, but it's not the problem they're not brushing. It's the problem that they don't have it in their mind to brush. It should not be something they should think about, but it should be automatically. So we try to do a lifestyle change, put it in a visible area, try to brush every day at the same time, so it becomes a habit instead of a motivation, because the motivation dies off. And if you have a habit, you will repeat this every day. So in this case, for example, our result already in 4 weeks, we saw a very clean soft tissue, the bleeding was gone. And when we probe the soft tissue, we probe around less than 3 millimeters. Already we got this result in 4 weeks. So that's what we do around peri implant mucositis, the use of the additional benefit of the actionated products. But it can become worse, of course. And one of the main topics on the peri-implant disease prevention is that we need to keratinize mucosa around our implants. I think that's very important. And if you look at this current case, you might think, okay, we need to do a lot of bone regeneration for this case. We need to place the implants. Well, the implants are already placed in, but we're lacking the soft tissue at this part. We're lacking the keratinized soft tissue. So to ensure around 2 millimeters of keratinized soft tissue labial or buccal around our implants, we need to do a apical repositioned flap from the palate to the buccal area. So we make the flap split thickness. I always rinse out the inside of the implant because I want to get rid of the microflora as much as possible. We connect the healing abutments and then we reposition our flap. But this kind of flap, it's almost an open wound, and this is quite painful for our patients. So what we do is also supply the oral gel to enhance the wound healing of our soft tissue. And we ask our patient to supply this oral gel for around 2 or 3 times a day. So on the one hand side, we get faster wound healing. On the other hand side, there's less pain for our patient, and also the inflammation of the healing goes faster and is less. So this is our result already in 5 days. You can see that there's new keratinized tissue coming up in between the abutments. And this is in 14 days. And after 14 days, we instruct our patient to start brushing the healing abutments again. And in 8 weeks, we got nice, thick, keratinized soft tissue around the healing abutments where we did not have that before. And if we compare this kind of the initial situation with the situation afterwards, we can see that there is a clear increase of the keratinized soft tissue around our implants, and our patients are now more able to keep their implants clean, which less chance of any inflammation around our implants. But the most difficult part is, of course, the peri-implantitis, and that's the bone loss. And already we've got some experimental peri-implantitis published by the group of Jan Linde in 1994. And I think one of the most important conclusions of their research is that there's no zone of healthy connective tissue around implants when there's bone loss around the bone which is supporting the implant. So if you take a look at the left picture, this is a experimental periodontitis around the tooth. So if you have the apical part of the inflamed connective tissue and the bone part, there's always a zone of healthy connective tissue which is protecting the bone around the tooth. But if we look at the implant part, we see that the apical part of the inflamed connective tissue is already going into the bone instead of there's a healthy connective tissue protecting that bone. And that's why we get a saucer-shaped, a big saucer-shaped bony defect around our implants compared to periodontitis. So it's a very big problem. And already we've got a cumulative interception supportive therapy proposal by Professor Lang in 2000. And as I know, till today, we're still using this same protocol also in the Netherlands to treat our cases around implants. So it's actually always the same around peri-implant disease. We need to do a flap. We need to remove the inflamed connective tissue, and we need to try to clean the implant surface. And according to the bone configuration, we can choose for an implantoplasty, which means that we're going to remove the threads of the implant and to polish it that the patient can clean it better. Or we do guided bone regeneration if we have a 3 or 4 wall defect, but that's not always the case, of course. So if you have a vertical defect, I think it's a better way to do a implantoplasty. So this patient was referred to my office. The implants were not placed by me, but this patient was referred to me because of the peri-implantitis around her implants, mainly at the distal implant. And this is what we mainly see around cases like this. If you open up the flap, you think, well, the bony defect isn't that large, but after you remove all the inflamed connective tissue, the bone loss becomes very sufficient. And since the patient in this case was also a smoker, I decided not to do any guided bone regeneration, but rather to just remove the exposed threads, do the implantoplasty to polish the threads, and just suture everything back. And this is our result, which we can achieve in a short amount of time. And the question is this a treatment outcome that we're happy with? Is it good enough? Well, I think this should be the one of the last resort. Well, the last resort after this we have is, of course, removing the implant and placing new implant. But this is one of the last resorts I have. So we thought of, together with the Blue M company, to come up with a treatment of peri-implant disease, and we call it the topical oral oxygen therapy. It's a non-surgical intervention with oxygen. So we try to do in a few appointments to do a cleaning with a patient, try to remove the inflamed connective tissue, apply the oxygenated gel inside of the sulcus, and to repeat that 4 times every 2 weeks. And we give our patient, of course, instruction of the oral hygiene. We try to change their lifestyle, and we ask them to use also these oxygenated products daily to ensure a faster healing of the soft tissue. So the tooth-directive topical oral oxygen therapy is mainly based on getting as much of oxygen inside of the soft tissue, inside of the sulcus. But because the inflammation is quite severe, we try to repeat this therapy 4 times every 2 weeks. So we're ensuring that the large inflammation around these implants gets to heal a little bit faster. And let me show one case how we use this situation. So one of the situation when we have peri-implant disease, when we probe, is that we get massive bleeding. There's a lot of vascularization, inflammation around peri-implant disease, around this bone loss, around implants, as you can clearly see on this X-ray. So first, our topical oxygen is we give anesthesia, we clean the site, we try to remove inflamed connective tissue non-surgically, and we apply the oxygen gel. We instruct our patient with a lifestyle change and try to get them to use these oxygenated products. And we do this every 2 weeks. So this is the first visit after the second visit after the first time we did the cleaning and gave the initial the cleaning and the lifestyle change and then the oral instruction to our patient. But you can see that the bleeding reduced massively already in 2 weeks. Of course, we still have pockets up to 5-6 millimeters because we're just only in 2 weeks. But in 4 weeks, we can see that the soft tissue is now retracting and is more tight around the implant. So already measly, we went down from a 5 to 6 millimeter pocket up 3 millimeters, distal 5. But you can see there's almost no more bleeding in 4 weeks. But we know that the inflammation is still large. So we try to continue this at 6 weeks, and the pockets is going less and the soft tissue is becoming more tight around the implant. And we do another one in 8 weeks and in 16 weeks, 4 months from the initial situation. We did a checkup and we got the inflamed pockets reduced up to 3 millimeters, and there was almost no more bleeding around these implants. And you can see the difference in already 4 months without doing any surgical protocol, without exposing all the threads, without removing all the threads of the implant. And this is, of course, the bone is not coming up, but we have a very non-inflamed situation anymore. So we can monitor this patient for longer term. If there's no bleeding, if there's no clear separation or bleeding on probing, we think we can try to get the situation more stable. So the last case before I end my lecture is what we do with a short movie and what we do around inflammation around implants, when there's clear bone loss, sometimes we still need to do a flap because not every case will respond the same, and that might happen. So we try to have a honest webinar, honest talk around this. So we open up the flap and we remove the inflamed connective tissue. And with a small burr, we try to do the implantoplasty by removing the threads. And once the threads are removed and it's polished, we just apply some oral gel around the implant. And then we suture up the case. Before we close up, we still rinse out the implant. You can also use this oxygen gel inside of the tissue. That's not a problem. You don't get any inflammation around the soft tissue. The soft tissue will react in a very nice way around this oxygenated gel. And then just we replace the crown for our patient because they still want the crown back to chew. I think this is a good option. And if this doesn't work, I think the last resort is to take out the implant, which I don't mind doing because sometimes if it doesn't work, it's better just to remove the implant as we remove teeth when they don't respond to our treatments. We place the gel also inside of the crown and then we suture up. So I think that was my 50 minutes. Is it moving? Yeah, so the oral healthcare goal, which we have in our practice, is to preserve, restore, and very important to maintain everything. So if you have any questions about this topic or anything else, just send me an email to irfan.abbas@gmail.com.
First of all, thank you for inviting me to talk with you about vacuum pocket cleaning, which is, I think, a promising addition to the treatment protocol. Yes, it will be next year that I'm 40 years a dentist, practicing as a dentist, and of which I think it's 35 years in implant dentistry, which is a challenging field in dentistry. It is a very nice addition to what we can do in dentistry as if you look to reconstruction of severe cases and several possibilities we have. But first of all, I think we have a very large responsibility into what we do as a dentist and as an implantologist, because we are placing implants. I shall try to maybe, just a moment, I'm stopping here because I'm going to remove this one as well, because then you can see the whole presentation, I guess. Sorry for that. Yes, we have a responsibility in what we do placing implants, because we know after several years that we also we give patients also a potential problem if you look to peri-implantitis. And as we look to more and more to the way of how we look to perio and implant diseases in general, we saw the last 2 years ago that the perio part in our occupation is looking towards perio problems more and more as an immune problem, and I'm not sure whether Victoria Sampson talked about that or Irfan, because I stepped in a little bit later. Sorry for that, but I will talk a little bit about that as well. So let's see where we are into. If you look to my presentation, which will be in peri-implant health and disease in general. And of course, Irfan talked a little bit about that, so I can skip something about that. Then we have current treatment methods for peri-implant disease. Vacuum pocket cleaning as a treatment for peri-implant disease. Then pocket cleaning in our clinic, what we do with the Fluxion device, and then we might have some discussion, and we have some references. If we look to peri-implant health, well, we can look to it as Irfan also said, yes, with the sisters system from Klaus Lang and Heitz Mayfield from 2000. And they revised it a little bit, and we know this schedule a little bit from the perio diagnostics. So if you look to peri-implant health in general, we look to absence of erythema, bleeding on probing, and swelling and suppuration. That's what we can look to from a clinical point of view. Then we have methods used to detect presence or absence of inflammation. So we have the visual inspection, probing, palpation, and enzyme tests. Well, and prevention is very important in this stage if we look to peri-implant health in general. So what can help us to look at the health if we use the IDRA system from Klaus Lang? If we look to peri-implant mucositis, and Irfan also talked about that, so that's not really something to go into detail, I guess. We see bleeding on gentle probing, which will like 25 grams of force, erythema, swelling, and suppuration, or suppuration, and the main etiological factor is plaque. The risk indicators are plaque, host responsible to bacteria, smoking, diabetes mellitus, and radiation therapy. If we look to the histology, you can see it here on the right side of the screen. We get an inflammatory infiltrate lateral to the junctional epithelium, infiltrate rich in vascular structures, plasma cells, and lymphocytes, progressive loss of collagen structures. And we have infiltrate does not extend apical to the junctional epithelium to supracrustal connective tissue zone. So most of the time we see in peri-implant mucositis that the bone is not affected. The treatment objective will be biofilm removal, and maybe I can a little bit reflect on what Irfan says, because topical application of something like Blue M gel, which is a very, very nice and very good way to treat those cases, is very promising, and I use it as well, and is the best we have, and I agree that it might be the last resort to do so. And you showed also cases here, Irfan, that we also can use that by doing open flap surgery and do it like and use it in the stage 3, like peri-implantitis with bone loss. And that's also a very good way to treat them. But maybe later on we might think about something to use before that, and to prevent all those kind of more difficult ways of treating peri-implantitis. So if we look to peri-implantitis, we look to the mucosa and subsequent progressive loss of supporting bone in comparison with the mucositis, the peri-implant mucositis. So the clinical characteristics are as like peri-implantitis mucositis, but greater pocket depth and apical migration of the marginal gingiva, as we all know. Radiographically, we see bone loss, and the main etiological factor is plaque. And risk indicators, periodontitis, poor plaque control, no regular maintenance care, etc., etc. We have data on smoking and diabetes at risk indicators are yet inconclusive, but albeit most appeal to common sense. Yes, stress is also a risk factor and risk indicator, as immune fitness, as we look to as we told before. If we look to the histology, then we have a dominance of plasma cells, macrophages, and neutrophils. We have apical extension of junctional epithelium. We have activation of osteoclast via rank and rank ligand. with resorption of alveolar bone. That is the most prominent difference if we compare the peri-implantitis with the mucositis. The treatment objectives are biofilm removal, decontamination of the implant surface, and how very difficult that is, showed Irfan as well, creating a cleanable situation, and to hope at least for re-osseointegration. If we look to the current treatment methods we have in peri-implant infections, then you can maybe divide that in 4 phases. Like first, the systemic phase, which is control of systemic diseases. The hygiene phase, optimization of oral hygiene, and yes, we can also look to that in a way of lifestyle changes, and lifestyle and immune fitness are related very much together, I am convinced. And more we look to peri-implantitis as something we might not always be able to treat it as a dentist. And we have to look a little bit different into dentistry than only looking towards teeth. The corrective phase, and we have that on a non-surgical and a surgical, and I think that is extensively covered by Irfan. And of course, we have the supportive phase, the maintenance phase. Well, if you look to the peri-implantitis, then the non-surgical and the surgical phase, as we saw, we have some of the issues. Well, if you look to the non-surgical, what is the golden standard? We don't know. If we look to the treatment of the implant surface, it is very much depending on the type of surface we have. Yes, we can use curettes and ultrasonic, but we know that we have titanium nanoparticles, and we might see phagocytosis. We have an airflow device, for example, is often described, but how deep does it clean? Does it, and we have a risk of emphysema. Chlorhexidine side effects after long-term usage, we all know, and it's not something we like to choose, but so far we don't have so much alternatives. And antibiotics is also a non-surgical therapy, but if we look to immune fitness, I think we might reconsider this. From the surgical way, we can divide it in a resective and regenerative way, as we've seen. But the questions are, what do we do in the aesthetic zone? A very nice case showed by Irfan, but what do we do in the aesthetic zone? Yes, we might need to remove the implant and start all over again. Regenerative, yes, this is a difficult procedure and a lot of requirements. It is expensive, and how predictable it will be. So there are a lot of questions, and I was happy to be shown the fluxion device, and well, it gives us the pocket irrigation based on the flux, and that's a novel device designed to irrigate the peri-implant pocket. So it's rapid alternating infusion and suction, which will cause a flux. And the infusion is like a low pressure liquid infusion, and the suction is vacuum and creates under pressure in the pocket. So for that you have the flux. The result will be a sulcus fluid is replaced by the liquid of choice. And that brought us in our clinic to think about what we could use in the fluxion, but I will talk a little bit on that later. Well, the potential advantages of the fluxion device will be that it is non-invasive. So it's solely fluid dynamics in the pocket. It's no impact on the implant surface. Yes, we can do a deep cleaning up to 9 millimeters. And I think with just a gel or topical application of chlorhexidine or just brushing, as in periodontics, we know that periodontal cleaning or just I should say, mouth brushing, teeth brushing will not influence the bacteria under the 4 millimeter of pocket depth. So, and the fluxion is a potential, has the potential to do a deep cleaning there. So it can replace the peri-implant clavicular fluid. It can cause a disruption of the biofilm by removing the parts of the biofilm, bacterial substances, and exudate. If we use, for example, a Blu-M oxygen, sorry, we come to that later. If the oxygen suppletion, for example, if you use the Blu-M, then it stimulates self-healing capabilities and reosseointegration, which is still a question mark, but it has a potential to that. And of course, if you look to patient comfort, it is a pain-free treatment and it has no aerosols. So the addition to the fluxion, we start on thinking, well, if we have the fluxion and it has this the mechanism, why shouldn't we take another fluid like Blu-M mouthwash? So this is what we started to do. And I don't have to add something about Blu-M because Irfan just already talked about that and pointed out what are the substances of the Blu-M mouthwash and an oral gel. So it can be used as a liquid in the fluxion, and it can give us an enhanced disruption of the biofilm compared to demineralized water. That was something we started to think about and wanted to research. So that is basically what we did, and I'm not sure whether you showed all
Als ik het zou moeten samenvatten, dan zou.
I'm not sure whether you discussed this already, but when we use the fluxion, and you can see here what we did with one of the cases, you see clearly how the device works. It gives like a flux, and you can see that here, like a pump working. And if we supply Blu-M mouthwash, we thought it could be a potentially contributing to the working of the flux itself. So if we look to the pocket irrigation in the Oosterwijk Clinic where I work, we had three components, three stages of the experimental approach we work with at the moment. The first component is like the scientific research we do and we set up. And the second component is the experimental cases I will talk about a little bit. And the third component is the daily application. And where can pocket irrigation with Blu-M contribute to the standards of care we have at the moment? First of all, the scientific research. We set up like a research, and we did this with the Groningen University of Dentistry. The student is a very talented student, Miran Meer, which is he's just only a very young potential. No, he's not potential talent. He's talented guy, and he set up the research together with this university, and the aim was to determine the effect of the fluxion with Blu-M as a treatment of peri-implantitis. It is a randomized clinical trial, and we have like a number of 60 implants randomly distributed over three treatment groups. One, we treat with fluxion and demineralized water. The second is the treatment group. We treat with the fluxion and the Blu-M, and the control group is like the airflow, which we are quite familiar with. At this moment, we are in the starting phase, and we are waiting for the authorization of the Medical Ethical Committee of the university. And the timeline will be that baseline measurement, clinical and radiographic variables and treatment. And after 6 weeks, we do the post-measurement, and we look also to the clinical variables. And after 6 months, we do the post-measurement radiographically variables. The variables are the probing depth, active matrix metaproteinase, the MMP8, which is a reflection of the patient's health, and peri-implant and periodontal health can be measured by measurement of the MMP8. Bingo probing, suppuration, plaque, and radiographical bone height. A little bit about MMP8. As I already said, I am convinced, we are convinced that the loss of bone around implants and around teeth has a very strong relationship with immune fitness. And yes, with how you live your life. But the last part you can not easily change. So, but we have to look at it. We can measure it. We can measure the amount of MMP8, and that is like a collagen-lytic protein. Is a chairside test by Implant Safe, Perio Safe. And it is to accurately determine the current state of the periodontal and peri-implant degeneration. It takes only 5 minutes, and it is a continuous result in nanogram per milliliter on a digital reader. And you see that on the right side of your screen. And the cutoff point we take is like 20 nanogram per milliliter. If you look to the experimental cases, we did a few extensive cases just to see how things were developing. We used diffraction with Blue M, and what are the clinical effects of one treatment. The documentation according to the scientific research protocol, and currently we have some severe peri-implantitis cases treated, and we saw a follow-up of 4 weeks. And yes, we have varying results. Let's look to the first case, very severe case, and it's an 82-year-old male, generalized oral complication, implant 3/6 treated, and a great improvement after treatment, yet inflammation and still present. If we look to the MMP8 measurement, as you can see in the lower part here. The second case is a 54-year-old female, implant on the 1/1. It's she had periodontitis. It's treated. She's recently stopped smoking. Yes, she's a stressful person, and we saw no improvement after treatment, and you see even a worse situation of periodontal and peri-implant breakdown. So that leaves us some of the questions. The 77-year-old female, implant on 1/4. The stressful person, generalized oral complications, and no improvement after treatment. The same thing here if you look to the measurement of MMP8. So that left us with a lot of questions, and the results are not yet optimal. And why is that? Well, I think we started with the wrong cases. If you look to the pocket irrigation, we started with severe peri-implant cases, which treatment will help. We are not yet comfortable with the cases we had so far. And the intended use of diffraction was peri-implant mucositis instead of peri-implantitis. What we also saw, if we looked a little bit better to the cases, that there were many risk factors for implant diseases in the treated patients. And the next step will be the same patients, more intense protocol as described by Hentenaar, for example. So we are going to change our protocol and do that more frequently. If we look to the pocket irrigation in Oosterwijk Clinic and the daily use of diffraction, nowadays that will be is done by dental hygienists and assistants. We treat peri-implant and periodontal treatments. And we have mixed opinions. The pros, mixed opinions by the dental hygienists and assistants. So it took a little bit of energy to convince them that it's the only thing we have if we look to proper pocket cleaning. And yes, if we end up in the severe cases we treated, you might have some less good results, so to say. The pros are the debris are clearly visible in the waste container, as you see on the right side. So you can clearly see it does something. It does, for sure, it works for the cleaning of the pocket. The treatment is a pleasant experience for patients. They don't feel anything. It's not painful. It's not too time in consuming. So that's really a pro. The cons are, I don't feel it does anything. This is what one of my dental hygienists said. She was working most of the time with other techniques, such as just rinsing, and she felt that this does not do anything, and unless we look to the container on the right side, and it is a little bit difficult to handle, so it needs a little bit of training. So if we look to the possible applications in the future, then we can see, if we look to the 4 stages of peri-implant diseases, that it has a potential contributing factor in the optimization of oral hygiene, and to assess and to minimize the risk factors. It has a potential advantage and possibility if we look to in the corrective phase in the non-surgical way, by remove the biofilm and decontaminate the implant surface. And yes, it has a potential advantage if we look to the supportive phase. So these are the references of what I was talking about. Again, thank you so much for being with me. I think I had to a little bit rush, but I think I'm within my 50 minutes. I hope so, at least. Thank you so far.